Hi, I'm Dr. Dipan Shah, Director of Cardiac MRI at Houston Methodist Hospital, and I'm here today with Dr. Michael Markl from Northwestern University. And Dr. Markl, let me start off by asking you to tell us a little bit about your background, give us a little bit about your biography, and give us a little overview of the Grand Rounds presentation you did for us today.
Sure. Hi, my name is Michael Markl. I'm a physicist by training, actually. I'm now the professor of radiology and biomedical engineering at Northwestern University in Chicago. I've received my training in physics back in Germany, and early on during my career I've become interested in imaging, and in particular magnetic resonance imaging. And in that context, over the past 15 years or so, I've been working on the development of new MRI technology for the imaging and assessment of functional cardiovascular function, and in particularly cardiovascular flow and hemodynamics. And that's also what I talked about today in the Grand Rounds, with a particular focus on the aorta and how aortic hemodynamics, aortic blood flow, or in particular aortic 3D blood flow, can potentially play a major role in the development of aortic disease, and in particular how new MRI technology, and in this context I mostly talked about 4D flow imaging, that's a new technology that's become available over the past 5 or 10 years, can potentially help to really change management in patients with common aortic diseases such as bicuspid aortic valve, aneurysms, and so on. We believe in our research, I think we've shown that at least partly, that this new technology can really be used to derive a better understanding of the underlying physiology of the development of the disease. And based on that, we're currently learning how we could potentially apply these techniques to better identify patients who are at risk for the development of disease, and then how to better tailor therapy to these patients to help guide surgical interventions and monitoring of patients over longer periods of time, and better identify those patients who may be needing an intervention earlier than others. I think particularly over the past couple of years, there have been very exciting developments in that field. The imaging technology that was initially very difficult to use has become more available at multiple clinical centers. It has been easier to apply the technology. At the same time, there have been multiple developments in terms of the analysis of the data that are critical to really extract parameters that are relevant for the individual patient and for the understanding of disease progression and patient management. So that kind of in a nutshell summarizes what we've been working on and others have been working on, and how we feel that these new MRI technologies can really help to not only better understand aortic disease, but better manage the disease.
Okay. Let me ask you, what do you think are the challenges or the technical barriers to getting this technology out to more widespread use?
Yeah, so that's a great question. I mean, at this point, it's really mostly a research technique that has been developed by us and other centers. Has also already been distributed to other centers, but it's really mostly run in a research setting and still requires a lot of local expertise with respect to the imaging protocols, the underlying engineering and physics of the technique. So it's kind of sometimes challenging to run, and in particular it's still difficult and somewhat time-consuming to analyze the data that's actually acquired by that technique, which also requires local expertise and maybe not as easy to use software tools as in other arenas. So really the two major challenges is to make the technique more faster and more easy to use, to provide a more push-button approach, and also to develop appropriate software that can very easily take the data that's acquired on these MR systems and translate it into something that's easily readable in a clinical setting. So really the translational effort is already ongoing to take this technology and bring it into the clinic, but there have to be better optimized workflows to really allow this technique not only to be used by experienced centers that have local engineering expertise and the knowledge to run these techniques, but really to bring it also to all sorts of clinics, big and small, where every technologist can easily apply and use this technique.
And let me ask you, right now with the current workflow, what do you think the typical post-processing time is to analyze one of these data sets, to generate the type of images that you showed us in your presentation?
Yeah, that's also a great question. So the imaging itself has become much easier. So you can probably do a scan in 5 to 10 minutes, which makes it sort of feasible. But then the transfer of the data, analyzing the data, and if I had to put a number on it, it's anything. If it's really fast, it will still take 30 minutes, but can be up to a couple of hours if you do a more elaborate kind of complex analysis of more advanced parameters. So there certainly is a need to bring that down to on the order of a couple of minutes to make it more clinically useful. The other challenge is even though you can analyze data relatively quickly within maybe 20, 30 minutes, it still requires a lot of user interaction and very experienced users of the analytic tools. And that also needs to be simplified so that it can be used more widespread.
Great. Well, great. So I want to turn the tables a little bit and ask you, along a slightly different line, if you could go back in time, what advice would you give yourself as a younger scientist? Because I think you've demonstrated a great model of someone who started with a basic science background and really has taken that basic science knowledge and applied that to really help us as clinicians better understand the pathophysiology of disease and hopefully to better understand how to manage patients. So what would be your advice to yourself or someone like yourself?
Yeah, I mean, I would almost turn it around and say, I mean, you're right. I mean, I'm a basic scientist, and I've kind of transitioned into the clinical field, or tried to apply science concepts to clinical problems. But if I could go back, I would try and get clinical feedback much earlier, involve clinicians and people who have a better understanding of the underlying physiology of disease much earlier in my work. It almost seems like you develop a technique and then you kind of after you've developed technique, you come up with an application in the clinical environment. It would be much better and nicer to have a better integrated kind of joint approach on the clinical and the basic science side to develop these techniques to kind of avoid some of the failures or spending unnecessary time on developing technique that may not be that useful. And had you talked to somebody ahead of time, you may have had an opportunity to better streamline your research, to better target it to a clinical application that is useful. I think we've still been successful, and I think we continue to be successful, to have a very good relationship with the clinical colleagues. But to have that happen earlier on, even during the training phase, would have been very helpful.
Yeah. So, so I think I would echo your comments, and coming from the clinician side, I think it's useful for us to get engaged with the basic scientist at an earlier stage as well. Because I think really ultimately I think working as a team is going to be the ideal way that we can advance science and advance patient care together in a rapid fashion, and really take these techniques that you're developing, that scientists like yourself are developing, and actually transition those quickly to actually help us manage patients and ultimately help us, I think, to improve the care of patients in the future. So with that, I want to thank you very much for making the trip down here to Houston. Thank you for all the work that you've done throughout your career. I think patients are going to benefit from this, and I want to thank you for coming to visit us at the Texas Medical Center at Houston Methodist.
Thank you.
All right.